Good afternoon. Welcome to this webinar session on MHGAP Kashmir. I am Dr. Hussain. I am the consultant psychiatrist working in Kashmir. I am also a master trainer for MHGAP and has been responsible for coordinating the MHGAP training in Kashmir. I am pleased that we had more than 60 people who registered for this webinar. I think we have people from UK, we have a professor, we have representatives of the organization from Pakistan, people from Iraq, from Kashmir, from other parts of India. Today's presentation is going to focus initially on the problems that we normally face in developing mental health services in the primary care settings. And the second part of my presentation will focus on how we used MHGAP training, monitoring, and evaluation to overcome some of those problems. I'm going to start this presentation by highlighting the various strategies devised by countries like India to improve the delivery of mental health services in the community, the obstacles they faced, and then followed by recommendations. Finally, I'm going to conclude this first part by various recommendations about how the Royal College of Psychiatry London can help in contributing to improving and developing mental health services in the primary care settings. The photograph that you are seeing on the screen is of a famous river Jhelum that passes through the heart of the city Srinagar, the capital of Kashmir. All these photographs, they have been taken by my friend Dr. Basharat, who is a consultant in medicine in States. I'm going to describe briefly the services or the psychiatric services that we have got in Kashmir. We have got a psychiatric disease hospital, that is the secondary referral center, that is a 150 bedded hospital and is the only hospital for mental health in the whole of Kashmir. It is the main referral institution for all patients suffering from any mental health illness. It provides to and fro referral services with other hospitals of Government Medical College, Srinagar. It also provides a teaching program to both postgraduate and undergraduate students of the Medical College, Srinagar, and also provides a rotatory training program to the medical interns affiliated with it. I am going to briefly explain about the district mental health program. This is the program that was basically devised by the government of India, and its basic primary principle included that it was envisaged a decentralized community-based approach to the problems, which include training of the mental health team at the identified nodal institutes within the state, increasing awareness about mental health problems and effective health seeking pattern, adequate provision of services to promote early detection and treatment of mental illness in the community itself with both outpatient and indoor treatment and appropriate follow-up measures, collecting data and experience for the future, planning, research and improving service provision. We try to use some of these principles and try to implement them in the implementation and the use of MHGAP training program in Kashmir. This is some of the dates and timeline with regards to district mental health program. If you see, in 2012, the WHO Executive Board adopted a resolution with regards to mental health and formulation of mental health action plan, which were proposed by India, United States, and Switzerland. We stress the incorporation of the mental health along with the social sector. This is the photograph of the famous Dal Lake in the heart of Srinagar, the capital of Kashmir. Now I'm going to briefly enumerate the limitation to the current services that are available. I think these principles or the limitation are applicable across the whole of, I think, the all of developing countries. There continues to be the treatment gap in the universal access to mental health services. The gaps are even larger with regards to preventive, promotive mental health program as well as rehabilitation services. We are too slow in realizing the basic human rights of the people with mental illness. There continues to be lack of technical support, including a range of inputs from establishing a mental health information system to human resource planning and implementing clinical management protocols. There is non-availability and amendment of guidelines without consultation or guidance, and regular consultation, feedback, and learning from the field also does not take place. There is absence of uniform guidelines and technical support, and which in turn resulted in the program being interpreted differently in different states. The important example is the integration into primary health care and the desirability of specialist facilities or satellite outpatient clinics, which was interpreted by district mental health program districts in different ways. And unfortunately, in most places, it was just reduced to a specialist-enabled outreach clinics rather than primary care-based delivery of mental health services supported by the specialist, which is the basic and the primary principle of the MHGAP training program. Now, with regards to the goals of the district mental health program, one of the review found that 85% of the health personnel stated that spreading awareness was the main purpose of the program, followed by integrating mental health and general health services, which was the second most important purpose. Psychiatrists and psychologists stated that the main purpose was capacity building of the health system for mental health service delivery. As we are all aware, there needs effective and efficient coordination between various organizations and stakeholders, both at the international, national, and the state level. And unfortunately, there is poor coordination even at the ministerial level. If you see in India, rehabilitation is a responsibility of the Ministry of Social Justice and Empowerment, whereas the mental health was the responsibility of Ministry of Health and Family Welfare. Many persons with mental illness, especially those with chronic mental illness, they require a combination of medical treatment and rehabilitation to facilitate recovery. So in order to provide the holistic care, we need to combine the treatment as well as the rehabilitation part, which in India is being delivered by completely two different ministerial organizations. The lack of seamless provision of health and rehabilitation can be partly attributed to this separation of responsibilities towards the health and rehabilitation and the lack of intersectoral coordination in the delivery of these services. There is also poor and lack of coordination at the state level. The government psychiatric disease hospital, it comes under the Directorate of Medical Education, whereas the primary healthcare centers, they are under the Directorate of Health Services or Directorate of Public Health in most states. Again, the lack of coordination between these two directorates impacted negatively on the implementation of the district mental health program. So while implementing the MHGAP training program, we focused on improving the coordination between the primary and the secondary care service providers, and we conducted MHGAP training program both in the primary and the secondary care in order to clarify the role of both primary and secondary care sector and to be clear about the ways in which they can effectively coordinate in delivering coordinated services with regards to mental health in both primary and secondary care settings. Another difficulty that we have is the lack of uniformity with regards to a nodal officer who is responsible for coordinating and supervising the district mental health program. In some districts, it's the district surgeon, while in others, it was the head of department psychiatry, and while in some places, it was the principal of the medical college. And also sometimes the location of district mental health program was based within the teaching centers of the secondary care centers. As there was no specific training or clear guideline or agenda, these teaching centers, they had little public health perspective and little experience or incentive to work in the primary healthcare settings. And it was difficult to accept the core idea of integration of mental health with the primary healthcare setting. As mentioned earlier, there was deficit of simple treatment guideline used by the primary care health worker in identification and management of the mental illness. This was the area we focused on when we used the MHGAP training module, because the primary aim of the MHGAP training module is to be simple and practical so that it can be used to train people primarily at the grassroots level, which includes both medical professionals and non-medical professionals, so that they can work in coordination with each other and deliver a holistic approach. We adopt a holistic approach to deliver services. There was no technical support group available to prepare and deliver such guidelines, and there was lack of focus on the rights of the person with the mental illness. Similarly, lack of sensitization of staff to avoid rights violation. There is no clear information for planning services. Not much information is available on attendance and clinical and functional outcome. Mental health was not included in the monitoring and evaluation systems, and absence of state and central monitoring systems, this in turn reduced the accountability. There were non-existent essential and periodic reviews with no scope for innovation and no information on outcome of treatment. There clearly was lack of trained and appropriate human resources, rigid recruitment for specialists, and a lack of involvement of the non-specialists. Lack of training for state nodal officers, program officers, and psychiatrists in the implementation of the program. In order to increase awareness and the role that the psychiatrist can play, the MHGAP training program specifically focuses on the training program, which includes training the trainers, where we involve psychiatrists so that they are clear about their role in the implementation of MHGAP and how they can contribute to delivery of mental health services effectively in the primary healthcare settings. There were issues about the content of the training, with health personnel wanting it to be done in simple language using case studies, increasing frequency and need for refresher course. This was the area we addressed while delivering MHGAP training. We used case studies, examples that the participants shared. We used the training methods of group discussion, role play, PowerPoint presentation, and general presentation. Duration of training was felt to be inadequate, and lack of training for professionals at primary health level like community workers. There was also glaring absence of training of social workers on their role in the mental health program. So in our training in the MHGAP, we clearly focused on these two areas, and we had quite a few community workers, social workers, nurses who participated in the MHGAP training program. The basic training had focused on hard skills, little emphasis on soft skills, ethos, personal development, and leadership training. There was clearly narrow understanding of mental health program, and the important factor that led to for district mental health program in not being effective was that it revolved around a medical officer at a primary health care center or a psychiatrist, negating the role of social worker, psychologist, nurse, community leaders, and specialist workforce. The role of the doctor was limited to repeat prescription or refer to specialists, as there was no uh, collaboration or support from non-specialist professionals who were not trained in assessment or coordination with the doctors in the delivering a holistic delivering services using the biopsychosocial approach. This unidimensional approach on an isolated medical model focused on symptom reduction with medicine and not on the recovery using a holistic biopsychosocial approach. Non-availability of treatment was clearly one of the areas that were identified that needed to be addressed. A review by Nimhans reported that drug list for management of mental health problems and epilepsy was too long and not based on any scientific rationale. Drug budgets used to get exhausted quickly because of purchasing expensive drugs. There clearly was little data on the availability on psychological and psychosocial treatment, and only few patients reported access to counseling services. Psychologists and social workers were largely utilized for administrative work and had little time for intervention with the client program. It was not oriented to a continuing care model, and hence there was little effort in actively following the patients and engage them in ongoing treatment or providing any form of community care. Clear failure of the process of care delivery rather than the concept of public health care. Lack of continuity of care led to extended stay of patients in the psychiatric hospital when they could be discharged with support in the community, and patients who are discharged have a relapse or a loss to follow up. Skill development centers, employment cell, counseling centers, they were non-existent, at least due to lack of trained human resources for these tasks. There was clear lack of involvement of users and caregivers. No near total absence of users and caregivers in the design, implementation and the monitoring of the program. There is also no provision for users and caregivers to question the health system or the staff when there was non-availability of care. There was poor NGO and private sector participation, which we tried to address in our MHGAP training program. Absence of organized approach to engagement with civil society actors. Bid to stakeholders, holder participation failed, with several dynamic players wanting to play a role but not being offered opportunity. There clearly is the presence of private sector but no mechanism for coordination for delivery of services. There is clearly a lack of systematic provision of services with alcohol and substance use disorders. Services for mental illness at the two extremes of life versus child and adolescents. Children with developmental disabilities, they are provided by the Ministry of Social Justice and Empowerment, whereas some school counseling services were provided by Ministry of Human Resource and Development. Older people were notable only for their absence in the program. There was no crisis management in the community and use of inpatient services were inadequate. Ambulatory services, daycare, mental health first aid, they were non-existent in the program. This is the recommendation that Professor Vikram Patel had made in the email that he communicated with me, in which he clearly mentioned that we should be focusing on training and specifically on competencies. The knowledge and attitude, we should be regularly reviewed and assessed. And he also stressed that the training should be used to develop collaborative relationship between primary and the specialist care, which is a key requirement for the successful integration of mental health in primary health care. So these are some of the recommendations that were formulated, that we need to evolve a collaborative arrangement with strong community participation, linkages with voluntary sector and civil society initiatives, with academic institutions from interdisciplinary backgrounds, to utilize the private sector knowledge and skill base with adequate safeguards against commercial interests prevailing over public interest. The district mental health program was going to be launched in 2013. It was around at that time we started the MHGAP training program, and we tried to link the MHGAP training program with the implementation of the district mental health program across the state. We discussed various options how the Royal College of Psychiatry could help. These were the recommendations that we discussed during our presentation to Royal College of Psychiatry, London. It was agreed broadly that the Royal College of Psychiatry could help with developing curriculum of mental health for primary care workers, curriculum development of mental health for other specialist workers, nurses, assistant medical officers, psychologists, social workers. Similarly, development on mental health for teachers, police, etc. Implementation should be focusing on teaching both specialist and non-specialist workforce, and helping with rehabilitation, developing of employment projects, residential services and outreach services, helping to improve intersectoral coordination and better liaison with the primary care. The other areas in which college agreed to provide support was the research with regards to evaluation of health intervention, evaluation of training and cost effectiveness, helping with guidelines, continuing education information system, trauma counseling for adults and children. It was agreed that the Iraqi subcommittee, with which college has been working for 10 years, would continue to provide and advise, guidance, and share their experience. Similarly, it was agreed that the International Voluntary Special Interest Group, which contributed volunteers for training in the developing countries, would be contributing the volunteers for training professionals in the primary and secondary care settings. This was the initial presentation. What we are going to do now is that in the second part, we will discuss how we use MHGAP training program, the problem we faced, and how we try to address some of the recommendations or some of the challenges that we discussed in this first part of the presentation.